Welcome to Derm School. Today we shall be looking at skin emergencies. We are going to cover 4 conditions: Stevens-Johnson syndrome and toxic epidermal necrolysis, SJS-TEN, erythroderma, generalized pustular psoriasis, or GPP, as well as drug hypersensitivity syndrome, DHS. We shall first look at SJS-TEN. This can be defined as acute life-threatening mucocutaneous reactions characterized by extensive necrosis and detachment of the epidermis. SJS-TEN are variants of the same disease. They differ only in the percentage of body surface area involvement. For SJS, we have less than 10% epidermal detachment. SJS-TEN overlap 10 to 30% epidermal detachment, while TEN is defined as more than 30% epidermal detachment. Risk factors for SJS-TEN are SLE, HIV/AIDS, as well as certain HLA types. For example, allopurinol, HLA-B5801, carbamazepine, HLA-B1502, lamotrigine, HLA-B1502, as well as phenytoin, HLA-B1502. Drugs are the cause in 80% of TEN cases and 50% in SJS. High-risk drugs include allopurinol, sulfamethoxazole, sulfadiazine, sulfapyridine, sulfadoxine, sulfasalazine, carbamazepine, lamotrigine, phenobarbital, phenytoin, phenylbutazone, nevirapine, oxycodone NSAIDs, as well as thiacetazone. You also have chemicals, mycoplasma pneumonia infections, viral infections, as well as immunization. What is the pathogenesis of SJS-TEN? This is a cytotoxic immune reaction aimed at the destruction of keratinocytes expressing foreign antigen. There is induction of apoptosis causing epidermal injury. You have drug-specific activation of T cells on the peripheral blood mononuclear cells. The drugs or metabolites act as haptens. They render the keratinocytes antigenic by binding to their surfaces. And the cytokines, which are produced by activated mononuclear cells and keratinocytes, contribute to local cell death, fever, as well as malaise. The time from the first drug exposure to the onset of symptoms can be 1 to 3 weeks, and it is more rapid with re-challenge. Generally, for type 4 hypersensitivity or delayed type hypersensitivity reactions such as SJS-TEN, we take a drug history up to 2 months prior to presentation. Next, you develop a prodrome, and here the patients complain of fever, malaise, and arthralgias, and this occurs 1 to 3 days prior to the development of mucocutaneous lesions. There is mild to moderate skin tenderness or conjunctival burning or itching, leading to skin pain, burning sensation, tenderness, as well as paresthesia. With painful or tender mouth lesions, patients can develop impaired alimentation, photophobia, and painful micturition, and they are often quite anxious. Then you have the skin lesions. In the prodromal phase, these can be mobiliform, targetoid, with or without purpura, and they can confluent rapidly. They can also start with diffuse erythema. Early lesions are macular areas with crinkled surfaces which enlarge and coalesce. Then you develop sheet-like loss of epidermis with a positive Nikolsky sign. Trauma causes exposed, red or oozing dermis, and this can be compared to a second-degree thermal burn. Recovery starts within days and is completed in more than 3 weeks. During this process, your skin, nail, and eyelashes can be shed. This is a picture of the atypical target lesions that you see in SJS-TEN, and you can appreciate 2 zones here, compared to erythema multiforme, which has 3 zones. So these lesions are mostly flat and irregular in shape, with a darker color in the center, and sometimes they develop central blisters. This is a picture of more widespread lesions in SJS-TEN. Mucous membrane involvements can present as erythema and painful erosions. In the eyes, you can develop conjunctival lesions with hyperemia, pseudomembrane formation, keratitis, corneal erosions, and synechiae. It is therefore important to identify SJS-TEN early and refer to the ophthalmologist when needed. Other findings include fever, tachycardia, hypotension, acute kidney injury or acute renal failure due to tubular necrosis, and in the respiratory and gastrointestinal tracts, you have sloughing of the epithelium with erosions. In terms of investigations, patients can have anemia, lymphopenia with or without eosinophilia. Neutropenia is an indicator of poor prognosis. You can also have high urea and low bicarbonate levels. Complications of SJS-TEN include fluid loss, electrolyte abnormalities, pre-renal azotemia, bacterial colonization and sepsis, a hypermetabolic state, diffuse interstitial pneumonitis, as well as gastrointestinal bleeding. These are some sequelae of SJS-TEN. For the skin, you can have scarring, hypo and hyperpigmentation, eruptive nevomelanocytic nevi, as well as abnormal regrowth of nails. For the eyes, this is more complex and serious. You can develop Zika syndrome, entropion, trichiasis, squamous metaplasia, neovascularization of the conjunctiva and cornea, symbolferron, punctate keratitis, corneal scarring, photophobia, burning eyes, visual impairment, and even blindness. For the anogenitalia, you can develop phimosis as well as vaginal synechiae. This is SCORE-10, which is a scoring system to indicate the prognosis of the patient with SJS-TEN. And each of this is scored as a point: age more than 40 years, presence of a malignancy, heart rate more than 120, initial percentage of epidermal detachment more than 10%, serum urea level more than 10 millimoles per liter, serum glucose level more than 14 millimoles per liter, and serum bicarbonate level less than 20 millimole per liter. If you have 0 to 1 scores, your predicted mortality rate is 3.2%, and this increases with increased scoring, with 2 at 12.1%, 3 35.8%, 4 58.3%, and you have a SCORE-10 of 5 or more, predicted mortality rate is 90%. Management of SJS-TEN, you need to diagnose the condition early and withdraw the offending drug. Place the patient in the intermediate or intensive care unit. Replace IV fluids and electrolytes. The patient will need analgesia. In early disease, you can use systemic glucocorticoids. However, later in the disease course, this can lead to more morbidity and mortality. Other treatment options are IVIG or intravenous immunoglobulin, cyclosporin, TNF-alpha inhibitors, as well as plasmapheresis. You also need to have frequent suction with oropharyngeal involvement, treat any infections, refer to the ophthalmologist and treat eye lesions early. You may need mucosal emollients. They can benefit from potassium permanganate baths, non-stick occlusive burns dressing. And if mucosa is involved, you need to refer to ophthalmology, gynecology, or urology as needed. In terms of prevention, make sure the patient is aware of what's going on and what they need to avoid, and never re-administer the drug and dose in the same class. We now move on to erythroderma. Erythroderma can be defined as generalized and uniform redness, infiltration, and scaling, affecting more than 90% of the body surface area. This is a serious and potentially life-threatening condition. These are the various causes of erythroderma. As you can see, you can't get the cause in about 23% where it's undetermined or unclassified, but 23% is due to psoriasis, 16% due to eczema, 15% drug allergy, lymphoma or leukemias in 11%. And then lesser common causes are allergic contact dermatitis, seborrheic dermatitis, stasis dermatitis with reactions, pityriasis rubra pilaris, as well as pemphigus foliaceus. Now, there are basically two stages in erythroderma. In the acute and subacute phase, you have rapid onset of generalized, red, thickened, and scaly skin, which can be fine and briny scales. Patients also present with fever, pruritus, fatigue, weakness, anorexia, weight loss, feeling cold, shivering, and they are malodorous. Over time, it becomes chronic and the skin thickens with exaggerated skin folds, and the scaling becomes large and lamellar. So you can appreciate on the left, it's bright red, all right, extensive involvement of the skin. And over time, it becomes chronic, which is thickened with a different type of scaling, which is more lamellar. Other clinical manifestations for the palms and soles, for patients with pityriasis rubra pilaris, Sézary syndrome, or psoriasis, they can present with hyperkeratosis and deep fissures. On the hair, you can have telogen effluvium or even alopecia. For the nails, patients can present with thickening of the nail plates or necrolysis and nail shedding. They also can have hyper or hypopigmentation. Lymph nodes are often generalized, rubbery, and small, but in Sézary syndrome, they are more enlarged. Patients can also have pedal edema. You must always look out for pre-existing skin disorders, especially for cutaneous T-cell lymphomas. And in a 20-something% of patients in which you cannot find the cause, often we need to follow up these patients and monitor for progression and any clues that can give rise to an underlying disorder. So for instance, if you can't find a cause, you may even have to do a skin biopsy every 6 months to make sure what's going on. Now, what are the dangers of erythroderma? Basically, it's skin failure or barrier failure, and patients can develop dehydration, electrolyte imbalance, and protein loss. They can also develop hypo or hyperthermia, systemic infection, hypercatabolic state, leading to congestive cardiac failure. And if they are treated with prolonged steroids, you can also get adverse effects from that. Investigations. For chemistry, they have low albumin with increased gamma globulins, electrolyte imbalance, as well as elevated acute phase proteins. You can present with leukocytosis. Bacterial culture from the skin and blood may be needed. And as mentioned, skin biopsy is important. You want to look at what the underlying cause is, and this may need to be repeated over time. Patients may require imaging with CT or MRIs and lymph node biopsies if there is a suspicion of lymphoma. Management of erythroderma. Patients should be in a single room with temperature control, and please discontinue unnecessary medications. For topical treatments, they require bland emollients frequently, and sometimes we even tell them to apply up to 1 to 2 hourly when awake. They also can benefit from topical steroids, okay? But I would say avoid ultra-potent topical steroids like clobetasol propionate because that can lead to a lot of absorption. Next, systemic. You may require oral glucocorticoids, and this generally is to induce remission of the condition. Antibiotics may be needed if the patient is bacteremic or septic. Antihistamines may be needed for pruritus. Supportive care is extremely important. You need to think about the cardiac, fluid, and electrolyte status, as well as replace protein. And always treat the underlying condition when you can identify it. Caution, please avoid systemic corticosteroids in patients with psoriasis if you are in the general medical or outpatient setting due to the risk of pustular flare, unless you're bridging it with another sort of treatment such as methotrexate or cyclosporin or even biologics if needed, or acitretin, really depends. Now the next condition is generalized pustular psoriasis, GPP. It is also termed as generalized acute pustular psoriasis or von Sambusch. And pathogenesis, the patients develop fever and leukocytosis due to the release of cytokines and chemokines from the skin into the circulation, and these patients may or may not have a history of plaque psoriasis. It is linked with certain genetic mutations. Of note, interleukin-36RN, and this has been used as a recent treatment target. CARD14, AP1S3, MPO, as well as SERPINA3. And these are possible trigger factors, including sudden withdrawal of injected or oral steroids, certain drugs such as lithium, aspirin, indomethacin, iodide, and some beta blockers, infection, pregnancy or menstruation, hypocalcemia, stress, as well as UV radiation. So once again, avoid systemic corticosteroids in patients with underlying psoriasis due to the risk of pustular flare when you withdraw them. In terms of clinical manifestation for the skin, there is burning, fiery red erythema that spreads in hours with pinpoint sterile pustules appearing in clusters. This become confluent forming circulate lesions and lakes of pus with erosions or crusting over time. Patients have fever, weakness, malaise, and leukocytosis. There may be involvement of the mucous membranes in which you have circulate desquamation of the tongue. Patients can also have onycholysis and shedding of the nails, and telogen effluvium can occur generally 2 to 3 months later. So you can appreciate the pinpoint pus as well as some confluence forming lakes of pus. And in pustular psoriasis, investigations are skin biopsy, bacterial culture of the tissue to rule out Staph aureus infection, and on FBC you find polymorphonuclear leukocytosis. Prognosis, relapses and remissions may occur. It may follow, evolve into, or be followed by psoriasis vulgaris or plaque psoriasis. General measures of management. The patients will require hospitalization or even ICU treatment if needed. Emollients and moisturizers for dry areas, intravenous fluids and electrolytes, as well as analgesia. Specific measures include topical treatments such as calcipotriol, tacrolimus, and mild potency topical steroids. Phototherapy can be used, but it is usually combined with systemic agents. Antibiotics can be required for secondary bacterial infection, and conventional systemic treatment such as acitretin, methotrexate, and mycophenol mofetil may be offered. Less commonly, you can use apremilast, hydroxyurea, colchicine, or dapsone. In terms of management, the most specific and targeted treatment as of now are interleukin-36 antagonists, all right? And these include spesolimab and imsidolimab. Other biologics that can be offered include your interleukin-17 antagonists such as brodalumab, secukinumab, izakizumab, and bimekizumab. Interleukin-23 antagonists such as risankizumab or guselkumab. Interleukin-12-23 antagonists such as ustekinumab. TNF-alpha antagonists, or less commonly, interleukin-1 antagonists. We now move on to drug hypersensitivity syndrome, or DHS. Drug hypersensitivity syndrome can be defined as an idiosyncratic adverse drug reaction which occurs in the first 2 months after initiation of the drug. It is also commonly known as stress, which is drug reaction with eosinophilia and systemic symptoms. Pretty self-explanatory. This is a delayed T-cell mediated reaction, and it is related with co-infection with HHV6 as well as genetic predispositions. The main characteristics of DHS are fever, malaise, as well as facial edema with lymphadenopathy or exfoliative dermatitis, also known as erythroderma. These are the possible causes of DRESS, and the common ones that we see are allopurinol, carbamazepine, phenobarbital, phenytoin, as well as sulfonamides. Early skin lesions tend to be a mobiliform eruption, often affecting the face, upper trunk, and the upper extremities. This may progress to erythroderma or exfoliative dermatitis. There is often infiltration with edematous follicular accentuation, and facial edema is very characteristic, especially when it's periorbital and may even blister. The patients may or may not have sterile pustules, sorry for the typo. There can be purpuric eruption on the legs, and with healing, they develop scaling and desquamation. The distribution tends to be symmetric on the trunk and limbs. So this is the mobiliform eruption in early drug hypersensitivity syndrome or DRESS. Now, with other clinical manifestations, it can also affect the mucous membranes in which you develop cheilitis, erosions, and an erythematous pharynx, as well as enlarged tonsils. On general examination, remember to look for involvement of the liver, kidney, lymph nodes, heart, lungs, joints, muscles, thyroid, and brain. For example, patients may develop hepatitis, carditis, interstitial nephritis, or interstitial pneumonitis. In 30% of patients, they have eosinophilia on the lab test. They may also develop leukocytosis, mononucleosis like atypical lymphocytes, signs of hepatitis and nephritis, and patients may have a skin biopsy or other biopsies of lymph nodes, liver, or kidneys. This is the Registrar criteria. You need at least 3, all right? Hospitalization, reaction suspected to be drug-related, acute skin rash, fever above 38 degrees Celsius, enlarged lymph nodes at 2 sites, involvement of at least 1 internal organ, and blood count abnormalities such as low platelets, raised eosinophils, or abnormal lymphocyte counts. So you can also use online Registrar calculators which are available for free. So the cause and prognosis, the rash and hepatitis may persist for weeks after the drug is discontinued and may recur when systemic glucocorticoids are tapered. Rarely, this can progress to lymphoma. Patients may rarely die from systemic hypersensitivity such as eosinophilic myocarditis, and the syndrome will recur if the drug is given again. Management, stop the offending drug. You can prescribe oral antihistamines and high-potency topical glucocorticoids twice daily, especially for pruritus. Patients will need systemic glucocorticoids such as prednisolone. Generally, a dose of about 0.5 milligram per kg per day will suffice, but sometimes you need to give a higher dose. Educate the patient and give a medic alert bracelet and make them aware of cross-sensitivity between various aromatic anti-epileptic drugs. So for the systemic glucocorticoids, in these cases, you often need to taper them slowly over at least 2 to 3 months. If not, the condition may recur. So the take-home message, you need to identify skin emergencies. Always remember, if you can diagnose one, always take a drug history, and you need to institute appropriate management and address complications. And with that, I thank you for your kind attention and have a nice day.